which, by the way, a reviewer could have some serious issues with that. A reviewer is likely to have serious issues with that, no matter how nicely you write the sentence. Because in the post-operative situation, you get a lot of fluid overload. That is not heart failure, just fluid overload. So if I'm reviewing this, I probably would challenge your diagnosis of acute decompensated heart failure. Because in a post-operative state, it's not uncommon to just have transient for overload. You see it. We see it all. You guys will see it. Damn it also.
So,
the post-operative stage is a very complex dynamics of hemodynamics, and it's not the same as somebody coming from home to be here. So I would be careful about using that term. You may want to consider switching to a slightly different terminology.
and provide references as well.
Yeah, you agree, Craig? In the post-operative stage, it's just it's a stage where people are giving fluids in and out, and people get swollen, they get edema, then they all diurese a week later. I mean, it's just a funny stage that you don't want to. I would be shy of calling that acute decompensated.
Let's see, we have about 10 minutes left, so what?
This calcium scoring, since it's been used in software, since it's semi-qualitative, you probably want to name the software that was used.
Yes.
Somewhere.
Yes, that's right.
Since it's methods.
One thing I wasn't clear about is that when you did the calcium scoring, what was the time period of the calcium score or doing the CT scans? I mean, I don't know if you mentioned it somewhere, but I didn't capture it. As to how long before the surgery was the actual calcium score?
Yeah. So the CT scans that we have were all obviously pre-surgery. The time frame was usually all these patients usually have a CT scan within a month or so right before surgery. So the time frame was that. But yeah, that's right. I should get the time frame.
Because I would think that they should be around the same period of time, right?
Between 3 to 2 weeks.
Okay, where is that to define the time frame?
For the calcium scoring.
Calcium scoring, okay.
On the bottom of the first paragraph of clinical outcomes on the first page, you start talking about a point system. I don't really, it just seems to start. What is the purpose of telling us about this scoring? Shouldn't there be a sentence to explain that first?
Sorry, what?
Let's see.
Clinical outcomes are the bottom of the first page.
Page 5.
All of a sudden, you're telling us about scoring, 1 point given for each.
So.
Oh, yeah.
Does that need maybe start a new paragraph and say?
Yeah. First page paragraph was suggested. Hopefully, would be better.
Yeah.
You need to introduce it, not just talk about it.
Yeah, I guess if we ask you just, why did you design a point scale system? You say, oh well, we did it because we wanted to have a gradation of whatever. So that should be the sentence. In order to establish a gradation of severity, blah 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 blah, a score system was designed, and then defined as table 3 or figure 7.
And if it's an entirely different point, it needs a new paragraph.
Because otherwise, you start with the price is right. You start defining as point and say, why do you even need a score system?
Okay.
And you're creating it yourself, so it's not something that other people already have done. So you cannot even say, we use this system by so and so.
Yeah.
So you have to introduce it with the why you need it, and then define the system.
That's a good point.
Yeah, that's very
In my head it makes sense, but
yeah,
Yeah.
that's correct.
You have the knowledge bias, so.
So what is the answer to the question? Why did you?
Yeah. Why did you need it?
What?
Why did you need it?
So yeah, it was a gradation of severity. So post-op complications, one versus having all these complications.
I thought you were going to tell me it was going to make it semi-quantitative.
Yeah.
Okay.
And a separate RD period was not a point that was looked at. RV failure and itself was not looked at in these patients.
So, yeah, specifically looking at RV failure, no, we didn't look at specifically looking at RV failure. But because this is the initial drafts, we do have some additional data that's coming in that's going to look at the right-sided calcification with an RV failure.
So again, on page 8, clinical data and outcomes. That first sentence, again, you're repeating yourself. Data and clinical characteristics were collected for, you already told me you did it. Please don't tell me again you did it. Thank you. So go straight to the results. Okay? The data, are shown in table, whatever, and then go into the, describe the results. Don't tell me again that you did it. This is the third time you're telling me that you did it.
It's bad to put the results in the methods, but it's also bad to put the methods in the results.
Mm-hmm.
By the way, I think you're really brave to volunteer this today. I just want to reiterate.
It's
well,
this should be good insights to you, and I hope you get a lot out of it.
No, it's great. No.
Yeah, this is like free peer
how
review.
many manuscripts, did you write this, by the way?
Yeah.
You wrote it. How many manuscripts have you written in your life?
In my life, like myself,
Yeah.
like maybe just one,
Yeah.
helping out.
So this is good.
Yeah.
You're doing really good, girl. You should have seen my very first one. So this is not bad at all.
So we have about 5 more minutes. What do we want to tackle? Big important points before we
The
go.
calcium scoring system.
Mm-hmm.
Do you need any? Was that done retrospectively after you looked at all these results? Is that a calcium scoring system that you use, or is a off the top of your head plan, or is it?
So
Do you need to describe why you did that?
So the calcium scoring system for peripheral calcium, there's nothing out there. So it's something that we developed, and
Well, that'd be a good thing to say.
Have I mentioned that? I think I may have mentioned that in the discussion that there's
Because that's your semi-quantitative
right.
approach. It's the inherent bias. You had nothing to go by. You develop what something to that effect. I think. Give yourself a little credit.
Yeah. You can brag a little bit here.
One small observation is in this constructive pericarditis, I saw your definition, and maybe I missed it, is how many patients were diagnosed using which criteria? So how many patients were diagnosed with echo criteria, how many patients were diagnosed with cath criteria? So that's useful because you always said, so you know how you're diagnosing, because there's a big debate, it's not as straightforward.
I think you see pericardial constriction on echo a lot more than you see clinical.
We don't do CATs, at least in our center. We don't routinely do CATs on a lot of our constricted patients.
So that's good to know, and because you mentioned all the criteria to diagnose it. I said I diagnosed with GAT this number of patients, with echo this number of patients, and clinical. I mean, it's what you're doing, just so it's good, but it's just so the persons know how to diagnose.
And one of the things, I haven't had a chance to read the whole article. I can tell you already, the discussion is too long.
Yeah.
Okay, this is a very simple observation. We should have a short discussion. But to me, one of the things that I would have, if you tell me I'm doing a study looking at the spatial distribution of calcium in constrictive pericarditis and whether the amount of calcium distribution has any impact on clinical outcome, which is basically what it's doing. My first thing would have been, okay, does the calcium affect the efficacy of medical therapy? Okay? A lot of these people probably were treated with colchicine, steroids, and goodies like that, because I know the folks at Cleveland Clinic are as smart as we are and Mayo Clinic. And this is new trend. The new trend is you give people a a course of medical therapy before you jump at surgery. So the first thing I would like to know is, okay, does that make any difference? You know, if you have a lot of calcium, is less likely that colchicine will work and you will end up with a knife or not? And I mean, I read it very quickly, but I kind of never saw that.
I did, yeah, that's true. I didn't really mention that. I see it.
And to me, as a clinician, that would be the very first thing I would like to know. You know, should I waste time with colchicine if the pericardium is all calcified, or should we just send it to the surgeon? Or no, go ahead, try it because it may work.
That's a great question.
See that? You have to look for the niche where the clinician is going to be interested in. You know, I mean, most people are not going to give a damn where the calcium is at the apex, at the tricuspid annulus in my cabal. Okay, I mean that may be of some interest to a small group of people. It's not going to be of great interest to the community of clinicians. But if there is an impact on how frequently the drugs work versus need for surgery, then that becomes important.
Do you want to
have
spend?
to find that niche that may be the impact for the reader or for the clinician.
Do you all want to take a crack at the title?
Yeah, I definitely need to confirm it.
It's too long and
Yeah.
it doesn't give the right message.
Right.
Yeah. But so.
Without looking at the paper, tell us what your number one goal was of this paper. Conclusion.
So our number one goal was to come up with
Oh, I'm
some
sorry,
sort of
conclusion. Number one.
What was your number one conclusion?
So our conclusion was one, we saw that pericardial calcium distribution is unique in pericardium, where it kind of encircles the
So
heart.
your goal was to correlate calcium scoring to clinical outcome.
Yes, that's encircled.
Okay, that'd be a pretty short sentence
But
compared to
to
what you
also look at the calcium distribution.
No, there's a lot of buts. You can't write the whole paper in titles.
So I guess two conclusions.
Okay.
For your title, when I first read the word disparity, I thought you were going to talk about some population disparities.
Yeah.
Oh, okay. Yeah.
I don't know.
Yeah, that
Say
term has a kind of colored. That term is colored. People infer population.
Yeah, population. Yeah. So I guess we use that because previous papers have amyloid populations have looked even sparing, so we kind of wanted to sort of give the same message. But yeah, the title is too long to
So if you can semi-quantitative calcium, pericardial calcium distribution, so it's associated with postoperative outcomes or something.
Clinical significance of compared based on a semi-quantitative calcium scores. Something. Mine is working away. He's going to come up with a magical title just to say. Watch.
Just one more thing that was bothering me, like in the patient population, there was 1827 patients presented with authentic pericarditis. I don't think you need to say excluding. You could say out of which 123 were ones that had CT scan, and that was our patient population. Really didn't do an exclusion here. You just could just say 123 patients.
Met our criteria.
Met our criteria, and I don't think narrowed down. Is it a legit?
It's also jargon.
It's also
Yeah, it's
Where are you so I can put it in the
patient
comments?
population.
Okay,
Results.
7.
Patient. Patient. And one more thing was, do you have diagrams for these calcium scoring patterns?
Yeah, it's in the
That would be interesting.
Yeah, there is a figure.
Yeah, it's in the
So, no one has described the spatial distribution of calcification and constriction?
No.
And you're pretty sure of that.
Yeah. As of last night. Yeah, these are.
We have to
So-
go.
So what's wrong with simply saying spatial distribution of pericardial calcification in constrictive pericarditis?
think what we wanted to emphasize was that calcium is not present in the ATEX area. So yes, we're just describing the distribution of calcium, but to kind of give a little oomph to the title, we wanted to add that.
But why is that so unique? I mean, was people thinking that the EPEX would be more, or what? I mean, what?
No, so the only previous, the papers that we have are like small, very small case series and case reports that do describe as like calcium bands and the atypical sparing. So it's not something that's brand new, like just found out. So it's been known in the past that usually the calcium spares the apex. And we don't know exactly what the etiology of calcium sparing the apex is. Some just find the combination of the hard. Or it's kind of in the pericardial fat distribution where a lot of the calcium deposits. So our theory is there's got to be some sort of process going on with that fatty oxidation or inflammation.
I mean, you could say special distribution of pericarditis indication in conceived pericarditis relation to clinical outcomes, although we didn't have that much of a relation. So that special distribution has not been previously described?
So the spatial distribution and this amount of population has not been described. So there are small case series and case reports that do describe like certain case reports describe like there's pericardial constriction band from the anterolateral LV and circling up to the RVAT. But they do describe that the apex is spared as well. But this is the largest to date that has described specifically quantifying the amount of calcium in the pericardium. It's not been done.
And there was no relation to etiology?
So no. So there's no difference in the outcomes, and there's no difference in the.
But of those patients, what's the total number of deaths in the trial?
The total number of deaths were. I'll have to go back and look.
I mean, you do say in one of your abstracts that it obviously underpowered. There was a numerical trend in the right direction, right?
I'm sorry.
Wasn't there a numerical trend in death in the right direction? The more calcium was associated with more.
So more calcium doesn't necessarily mean more death.
Right.
That's been shown in previous studies. So we're looking at this.
Thank you for doing this.
Yeah, I know everybody needs to go.
Not a bad job at all.
So next time, what would you all rather just jump straight into the manuscript so we have a little more time?
This will helpful.
Yeah.
This people were like.
Yeah, because we really ran out of time on that. So I'll send you everything that I can catch from the group. And if you have any